Okay, Bismillah, sallallahu alaihi wasallam, wa ala alihi wa sahbihi wa wala. So assalamu alaikum everybody. It's a pleasure to be with you again this evening. I hope that you've been getting your fill of intellectual skills from the rest of the group. So this is my second session with you all, inshallah. So as is the habit and the good practice, we start with the dua. The dua that actually Sister Fatima had given us was a good one. I mentioned to you last time that usually I just start with the duas that our sister, the teacher, has sort of given me, but one that she has a particular view on things, so I'll share our benefits of the session. So the one that you gave, I think, Sister Fatima, was اللهم آت نفوسنا تقواها وزكها أنت خير من زكاها أنت وليها ومولاها. Oh Allah. So it's about the dua. So it says that Allah purify my nafs, my soul, and the bring taqwa to my soul, then purify my soul, for you're the one who basically is the caretaker or the guardian or the helper or the assister of souls, which I think is a good one, alhamdulillah, to talk about the masjid community, because the idea of the masjid community is that it's right. Oftentimes scholars say, or at least they tell me as a physician, you take care of the body, I take care of the soul. What's more important? So I agree that much is about taking care of one's soul, perhaps in the Muslim community. So it's a good dua, may Allah accept it from us.
Self-selected, by the way.
What?
Self-selected. Self-selects these
okay. So safe is good dua, inshallah. So may Allah help us purify our souls as we approach this honored space for us. You all know me, I'll skip over that. So today, we're going to talk about applying Picori's engagement principles to the masjid. We're going to talk a little bit about the value of a cab. And by a cab, I don't mean the taxi, but the community advisory board. We're going to talk about identifying a project, a partner, and a topic, and the PCOR research. And then a little bit about keeping engagement high. I will say that last time we didn't have much engagement from the cohort of CHWs, and I'm expecting that you all engage in the conversation because you all have experiences that I think will be of value to the conversation. So if you have time, inshallah, again, we want to close by Maghrib time or so. If you have time, I'd like to hear from your experiences and talk a little bit about these two models of engagement. So we started off last time, we ended near last time when I presented a slide that had this, right? Mosque PCOR stakeholders. And on the left-hand side, the right-hand side of the slide were the 9 categories of stakeholders that the Patient-Centered Outcomes Research Institute, PCORI, considers. And on the left-hand side of the slide, we talked about, well, we think that they're all present in the masjid, right? In some capacity, that you would have individuals from each of these stakeholder groups present. Now, I also shared with you the idea that what's central to PCORI is the idea that there are patients and caregivers, not patients and doctors, but patients and caregivers. Meaning that everybody in their life is a patient and everybody in their life is a caregiver, right? You're a caregiver for a child if you're a parent. You're a patient when you have a sore throat. So that these are experiences, that these are roles that we play in our lives at all times. And when we think about patient-centered outcomes research, and perhaps Dr. Rebecca had mentioned this before, we're trying to think about the value of research that we're doing, the generalizable knowledge we want to create to this group, particularly the patient, the one who is suffering from some malady, but also I think at the core, also the caregiver for that individual. So back to the masjid, in a sense, that we have at the core those individuals, everybody's a patient, everybody's a caregiver, so you have that stakeholder there present. And we think that we know that masajids have ancillary institutions like clinics, sometimes in the masjid itself doesn't have a clinic, but it has a space that is used to do health education activities. So there are these healthcare system aspects there, or the health sort of informing aspects there. We move beyond that from the core to the primary to sort of researchers. So all of you, if you are going to don the hat of being a community health worker, we are trying to get you to become community health workers that participate in research. Right. So all you will have as part of your identity a researcher identity. Then beyond that, we have hospitals and healthcare systems and payers, right? So there, I mentioned clinics, sites of healthcare delivery, but healthcare is not just allopathic, right? We have individuals in masjids who perform ruqya, which we'll talk about later on, right? Or who might be counselors, imams like counselors. So there is an expansive notion I want you all to think about of that there are people, hospitals, and healthcare systems. And this term healthcare system is one we'll blow up in a few slides in a second. But if you think at the core, moving from notions of illness to wellness, there are a lot of different healthcare delivery things that happen in the context of a masjid that include counseling and spiritual and worship-based treatments. Moving beyond that tertiary, the idea of purchases, industry, and policymakers. So the masjid board is a policymaker. They decided to close masajid during COVID pandemic. They enacted a policy that was on the basis of health information. So you might not think of it as they're making, PPACA or health Obamacare sort of policy level decisions, but that was a policy level decision made by a group of people who you wouldn't consider traditionally to be policymakers. Yeah, in the context of patient-centered outcomes research, I think that's incredibly important. So again, I'm trying to have you broaden your ideas about what who a patient is, what a caregiver is, what is healthcare, and how the masjid context is one where all these things intersect. You just have to frame it a bit differently. Okay. And when you all, inshallah, will write PCORI grants, or at least when Dr. Rebecca and Fatima write their next set of PCORI grants, you will be able to involve us in reconceptualizing the space. So next, inshallah, you've seen this slide as well, I think, from the last talk around PCORI's engagement principles. And that we've kind of broken it down to 4 of reciprocal relationships. The idea that in the context of decision making about projects and programs, that there's a reciprocal relationship between what is traditionally considered the community, meaning the masjid stakeholder group, and the researcher stakeholder group. There should be collaboration between them, including defining the boundary points of the relationship. There should be core learning, meaning there should be a value proposition for both the researcher and the community, right? So I, as a researcher, let's just take a simple example. I, as a researcher, will benefit because I can apply for a grant, or I can write a paper that'll have my name on it. But that is not currency that is of value to the community. And so this overlaps, PCORI principles overlap with CBPR principles. The question is, what is the value proposition for them to engage with you and partner in this project? We should make that value proposition up and central. And perhaps if Dr. Fatima has told you that these should be baked into the project charter, right? Clearly when you embark on a project. Partnership. So the idea is that there is a value of people's times when you partner. The many different things we can talk about in terms of partnership and the different levels of engagement. But at this point, I'll sort of simply say that partnership can mean, at least in the masjid community context, so let me preface it that way, partnership can mean various different things to people. A patient and a provider are partners, but they're not equal in power. A mosque board and you as a community health worker are partners, but you're not equal in power. And so I think we have to think about the culturally embedded notion of what partnership means. And often projects fail because we have different expectations of what that partnership will look like. And therefore, again, let me reaffirm the fact that the project management methodology that Sister Fatima is teaching you all is incredibly important to iron out these details. Lastly, there should be transparency, honesty, and trust, right? We should make our best efforts to be inclusive and share information about decisions and processes and reports. Sometimes, that requires adjustments in the way that we communicate. So I'll just say that. Now, the center to all of this, I think the core is presence. Why I say that is because we're in a society, and I'm going to date myself, we're in a time period and an epoch where I think that a lot of the younger generation does not recognize what presence means to the older generation. And when you're in masjid communities, oftentimes, unfortunately, the older generation is in positions of influence and power, not the younger generation. So the fact, and I'll give you this fact right now, the fact that I am here, and just a personal anecdote, I am here in my office at the medical college with the video on, but you all do not have your video on. I don't even know if you're listening. right? I don't feel you're present, but yet I am doing this. This to me is not equivalent in presence. I'm giving my full attention to this talk. I prepared it, spent hours on it, and the ability for you to not, I'm not pointing it out, but for me, for my generation, the fact that I can't see your faces or that, you know, you're not, it doesn't seem that's equal in terms of presence. Now, it could be that there's many reasons why you don't have your video on, and I'm not telling you to turn your video on, but these sorts of cultural nuances are problematic when you embark on projects, right? You can imagine, let's take a different example. You come to a masjid board meeting and everybody has laptops open. Yet the 70-year-old mosque president will say, what are you talking about? Like, are they listening to me? Are they, whatever, FaceTiming as someone else or whatever else? Are you on Facebook? So I'm saying this because you no longer should feel that your notion of presence is one that you have to meet, but rather the notion of presence from the group you're trying to engage is where you need to be at. Hope that makes sense. All right. So moving forward and moving us less into sort of some, into the space, I want to kind of talk about the notion of how you mobilize stakeholders based on best practices from my own work. This is where I can speak authoritatively to, and others in your own experiences or others in this meeting might have other experiences. So I welcome your edification, but for me, from my experience, I think that the idea, again, listen with presence, right? So this is actually prophetic in nature. We know that Rasulullah, when he would, and I don't meet the standard 95% of the time probably, but when someone was speaking to him, he would turn and devote his full attention and gaze upon that individual within permissible bounds. Right? He would physically turn his body towards that individual. So I think that in the idea of all these sorts of, I'm on my phone or I'm texting, I'm on the screens, all right, or I heard you, whatever, these sorts of things sometimes get away from the prophetic model. And again, you have to recognize that there is a hikmah within that. All right. So I'm saying that we should listen with presence and do meet and greets, and the meet and greets are for us. I am the research team. I'll give you an example from my own work. I was doing a study in Michigan, and we were going to do a partner project with, I think, 5 or 6 masajid. So I literally, on one day, on a Saturday morning, I took my entire research team in my SUV. I said, we're going to go do meet and greets at every masjid today that we're going to be participating on our project with. We're going to meet with whoever's there, the janitor, right, the imam, the school teacher, whoever it is. We're simply just going to meet and greet so people know who we are and why they might see our faces, all right? Because it can't be just on the day of your program, you want to go and here's who I am, here's my title, here's my ID. Like, you have to show who you are. I mean, so we all went. And we bought breakfast, lunch, and dinner that day on my SUV because it took a while. But that's what we did. So I suggest that you think about it in that some sort of way that, unfortunately, COVID's here, but you can arrange meet and greets in virtual spaces. So people who know you are without an agenda. I'm just here to, to introduce myself. And I think that can help ease a partnership. You've heard about informal needs assessment or formal needs assessments from Dr. Rebecca. I'm talking about informal needs assessments. So I would suggest, when we facilitate these partnerships and you're going to use a social engine, you should have your sort of antennae up to think about when people are saying something about health or life or illness, that content should sort of be put aside. You should earmark, take that content, put it aside, but record it, because you need to understand what that community is talking about in terms of health and wellness and life and challenges to those sorts of things. And not in a formal way. I mean, I'm not interviewing you about that, but when people mention these sorts of things and on your social engine chats, I'm very serious that you will not understand their notions of what's happening until you sort of start, okay, I'm going to highlight that word all the time and see what the content is. And then when you're doing meets and greets, same sort of thing, right? Oh, I am a community health worker. Well, I want to understand what the community health challenges here are. I mean, it can be done in that sort of way. Or what does health mean to you or to the community here? And then we should be specific in sort of building these coalitions of partnerships to think about what is the sort of the history of health programming in this mosque community. What have been the successes and failures? if you don't learn that in your initial sort of step one, right, listen with presence, then I think you'll be doomed to repeat those failures. And I'll give you an example again from my own work. Several years ago, we had this nice coalition of various partners, national and local, Imana, MHP, Masjids, CIOGC, blah blah blah, all wanted to do a tobacco cessation program in masjids. We had several meetings. I still have the emails. But there was certain individuals who were very mobilized and engaged to do that, but they failed to recognize that you already had programs that had failed by just putting up signage around, tobacco and it's haram or it's makruh and whatever else it is. So they wanted to repeat something that had already been done. So when you went to the masjids and say, we're going to do this, what did they say? We don't need you. It was a failure before. So you mobilize all the stakeholders and maybe even funders to get all this work done, but you failed to recognize that had already been done and failed. Yes, it wasn't found in the literature search or whatever else it was, but there was no appetite for that programming again. Now, and neither could you, the way to save that would have been, we studied this before, here's what the failure was, here's how we're going to fix that now. But you can't have that conversation until you understand that. So anyway, those are my comments to step one. Step two is then finding potential partners, right? So when you're in masjid communities, we just delineated there are many different stakeholders. You have to listen to who the decision makers are. You have to listen to identify who the decision makers are, right? And it might not necessarily be the people in formal leadership positions, right? So it might not be the board, or maybe it is the board. I don't know, maybe. But you have to. That's one of your goals. Find those potential partners. Involves knowing who the decision makers are, because they could be your allies or they could be your obstacles, right, to your project. Learn who the on-the-ground doers are, and have a better word or phraseology for that. But there's always, as we know, Dr. Aisha Sultana is the one who implements everything at MEC, right? Or she used to be, right? She's not in any position. She's on the health committee, women's, who knows? But every time you need something done, she's the one who you ask her, right? And Tayyiba Ahmed at MEC, right? For the women's. My point is that they might not have leadership positions, but when you wanted something done, they know who to contact, who's got the key to the masjid, who's the one who's going to get on the newsletter. They know everybody, and unless you involve them, you're not going to get the full volunteer capacity of the masjid in your project. Lastly, you must know the two leaders, right? Who's on the committee, what boards, and you can easily find that nowadays online on websites of masjids, as well as on newsletters. So those people you need to know. Even if it's just about FYI knowing, you need to know who they are, because they need to get the proper, introduction to yourself, the projects, and the purposes of things. And then, so that's step two, right? First, listen with presence. Step two is find potential partners, and I didn't put, but you can put obstacles, right? Or detractors from your work. And then thirdly, step three is building a coalition. So if you want to mobilize the community, you have to have a coalition. You yourself are not going to be able to accomplish anything that's going to be durable and sustained. And it's actually potentially, maybe you can't do yourself anything because you just don't have the time and capacity. So you need to have a coalition of partners to implement the work that we want to do, whether it be online, whether it be in person. You always need that coalition. And so key to that, and one way to go think about that is multi-sectoral community advisory work. Now, before I go there, I want to share with you some of, I said that I'm speaking from my own experiences, and I want to share with you some of this work. So we talked many years ago, this is a paper that put together of the research that we did in Michigan. And we talked about CBPR, which is community-based participatory research. And so that paper talks about it's a work in progress. I actually don't believe that CBPR is ready. The masjids are ready for CBPR, and that there were lessons learned. That's my own view. That I think the idea of full community-based participatory research is not yet ripe for masjid communities. And we actually discussed that in a podcast after you'll see the transcript on that after the manuscript. However, these sorts of preliminary work that will be a benefit to you, that sort of project still helped us to get a better conceptualization of what healing meant. As I told you, right, this idea of challenges to life and health, first you got to define what that thing is. What is healing? And then who are the key agents in healing and their roles? So this is foundational work for all of you, because we were very detailed in trying to come into the masjid, just take a wide-ranging view of what things are, not the program, but what things are in the masjid. What's the infrastructure? What's the notions of healing? Who the agents are? And lastly, I'll sort of say is that even when we want to do an intervention, like we want to go and help improve Muslim women's breast cancer screening or create a culture of health around Muslim women's health, we went back to the community to understand how we would do that, right? So it wasn't that, okay, we learned what healing means to you, then I'm going to bring to you some fandangled methodology and trial something from somewhere else. We made sure that we wanted to understand their perspectives as the recipients, quote unquote, of this intervention, of how we would design it. So I think you should recognize that there is knowledge, informal and informal, within the Muslim community. As I said to you last time, although I'm not using the same vernacular, you want to make their known, right, which is our unknown, a known. Yeah. Okay. All right. So that was a little tangent. Let's go back to the idea of a cab. So you'll have this this figure within the toolkit about what we think a composition of a mosque Peace Corps study cab community advisory board should be. But before we go there are some questions for you, and so you're going to have to participate, because last time I felt it was crickets all the time. So what is a mosque community? You can unmute yourself and tell me that. And while you do that, I'm going to have my lunch, which I haven't had yet. So some grapes here. Just to tell you that I have no problem with silence.
Are you asking about the advisory board or the whole community?
What's a mosque community? I gave you a definition for that last time.
Well, I guess it's just like all the participants of the mosque, like whether it be the people who are in charge or the musallis, people who volunteer, people who go there just for Jummah. And
You're getting there. Anybody else? Yeah, so Jimmy, does include schools.
yeah, schools.
Anybody else want to chime in?
I guess anybody mosque serves would be a part of their mosque community. Anybody they serve, it could be a Muslim, non-Muslim, anybody from the neighborhood they're in, anybody they serve.
Right. So in a way, so I said that the mosque is a social network that is centered around a physical space that involves the masjid and ancillary institutions around it. Right. It's a social network. That's what a mosque community is. There are people who are involved with physical that are with various things, masjid, schools, communities, whatever, right? Halaqas and salah and whatever. But it's a social network centered on a physical space that has ancillary institutions connected to it. There might be a clinic, there might be a school, as you mentioned. There might be, might be host to some, maybe the masjid has a banquet hall and hosts weddings. Those people who come to those weddings are part of the community. So expansive view. All right, good. So why do we need? So that's knowledge. That's a knowledge test, Fatima. That's a knowledge test. So now let's move to more conversation piece. Why do we think we need a community advisory board? And none of the people at Worry Free Community can talk. Okay, Andy. We need community input for what? SubhanAllah. Perspectives on what? Very good, Shala. I think that's a good definition. So the idea, I hope you all look in the chat, like we need to know exactly, right? And right, we need to know the community advisory board. We need to know what they need, right? And very good. We need a CAB to help facilitate, right? So there's many benefits. So I think very good. So the idea that we are not the ones who know at this stage. They're the ones who know, right? So they're a source of knowledge for us, both sort of explicit knowledge as well as implicit knowledge. They're the ones who can identify and speak to the community's needs. They're the representatives of the community, but also in the conduct of any project, these are the individuals who will be able to facilitate that work, right? Influence the community, but also help every stage of any project that you're doing. They're going to be your liaisons to this social network that is the masjid community. So it's critical. And there are various reasons people enumerate in CBPR work or in PCORI work why, but I'm just giving you sort of like, the rule of thumb of why. Next question. So I've said that this term multi-sectoral CAB, right? And this figure, this sort has people on the CAB from different walks of life. They all different stakeholder groups. So can you all think of what the cost would be of that and the benefit? Like having people who are from different sort of professional backgrounds or different relationships in the masjid. What is the cost and benefit of that?
Can you elaborate on the cost of benefit? I'm sorry if I'm not understanding correctly.
So having people who are, so you have a mosque, look, think this figure is what you have. You have 8 people in your CAB, and then one's a patient, one's a physician, one's a leader of the Islamic school. The other person is a healthcare researcher. One person is on the board of Blue Cross Blue Shield. The other person is a pharmaceutical, works in a pharmaceutical company. One person is on Obama's, on Trump's cabinet, a healthcare policy maker. Another person, is a hospital administrator. Those people are in your CAB. What's the cost and benefit to that? Like, what is do a risk-benefit analysis. If you got all these people here together, what's the benefit of these different groups, like these different disciplines? And what's the cost of that?
I would say that the benefit is that you get multiple perspectives from different areas, but the cost would be that everyone is there trying to fight for their own agenda. So, yeah.
Very good. Other thoughts?
Another cost can be that because of those differences, it could sometimes create maybe an issue on that.
Meaning?
Like just the difference of opinions sometimes, so it'll be hard to choose what is right, what is wrong.
Correct. So I think that right. So very good. So I think that there's a benefit that you get multiple perspectives, but that's also the cost. That bringing consensus might be difficult, and the cost is not theirs to bear; it's yours to bear. You're the convener of this group, right? So now either you can be authoritarian, what I say goes, or if you want it to be a more collaborative, we talked about the principles, you want to be more collaborative decision making, reciprocal relationships, you have a lot of costs of how much time you spend to get the group around consensus on anything, and whose view is most appropriate to enact on any topic. So let's work through this example for a second, okay? So what do we think? And what's really important to do that, to when you venture in, is to make sure you can understand the lens someone else is coming from. So you're going to have to be at the center of all these perspectives, and you must be able to validate and understand what the perspective lens someone's coming with. So imagine you're in the masjid, you're doing a project, and the imam is on the community advisory board. What do you think the imam is worried about? What are their primary concerns? And then what are the, well, I'm not asking, I'm going to enumerate to you in a second. So just rhetorically, so you have to know what are their concerns about whatever you're doing. You also have to know what are the benefits of their being there. So, right, similarly, if you have a clinician, because you have a lot of masjid, physicians and clinicians in the mosque community, what is their, what's the benefit, what's the lens that they're looking at through? And what are their concerns? And then similarly, which you often forget, what about the people who are attending the masjid? Oftentimes on your community advisory board, you have people in positions of power, but you forget that the people who you want to engage with, who you want to do the work, or the intervention, whose lives you want to benefit, they're not there. So an example would be, okay, this is a real, I've written on this. It's going to be a book that's coming out soon, inshallah. But let's imagine that you are now doing a project. I mentioned this, I think this last time, on trying to get people healthcare and Obamacare, whatever. You want to get them enrolled to Obamacare. So what's the perspective of the imam on that? We spoke about this last time, that the imam might know, if he's a jurist, well, is this a halal or haram modality of taking care of people's health? Right? Maybe that's their perspective, that they're worried about the salvation, meaning the eternal salvation of the musallis. And so they want to make sure, the legal perspective, Islamic law perspective. The clinician's perspective would be, well, look, we want to do an Obamacare or whatever intervention. I need to be able to give them guidance of where to get into the health exchange, because it's not just, I sign up here. You have to figure out the health exchange portion, whether we have a health exchange, and the cost related to that. So we actually someone who can give them more than just go sign up on a website, but counsel them through the process of signing up, and then help them select their primary medical home, because their view is, I want to help people not just sign a form, but get to the care, right? And then the patient's perspective might be, well, I have a sick wife or a child. I need to see a doctor now. So is this intervention to get me enrolled going to actually help my daughter who's got strep throat? And so the idea that so my point is that when you're doing this intervention, you must have programmatic material and conversations about all these different viewpoints. You might want to have a pamphlet that discusses both the legal perspective, Islamic law perspective, as well as the entire process of how you sign up, what exchanges are, what they do, like that whole thing. And you might want to have resources at the end. Well, if you need immediate care, here are the urgent cares to go to. Don't worry about it. You see my point? Like, you have to engage with all these perspectives. And when you're these people are in the cab, they all have different notions of what they need to have there. And so there's a benefit, but there's a cost. The benefit is that they get these perspectives. The cost is, I got to make something that meets all these people's needs. And that might not be what you're funded to do. Just to be honest, as a researcher, that might not be what I'm funded to do. Right? So just bear that in mind. All right, so I gave you some pointers and I gave you some ideas. Let me give you some quick cut and dry pointers and caveats. First, you have to, at least I believe, maintain equity in voice. Right, so you have to be inclusive and not authoritative. Right, so our community structures, I make the joke. I've heard this joke, so I've adopted it. That and those who are from the South Asian background will might not, fully appreciate this, but I think that a lot of the people reproduce same structure of authoritarianism that their home countries have. So if we're used to a culture of a dictator in government as our president or prime minister, then we try to, when I want the Muslim board, that's what I want to reproduce. So we have grown up, as some of us as immigrants, not myself, in these structures. So I only wonder what's going to happen in 2025, 2050, when we have lived through the Trump presidency, and what kind of masjid boards will look like after that point. Because we just reproduce the same structure. I think that's what ends up happening. So we have to actively work against that. Avoid dual roles. So in the exercise that Fatima remembers that we did at our Learning Institute for the eMarch project, I had people say, you're going to go into the Muslim community, what hat are you wearing? And only wear one hat, not multiple hats. Right? And the same thing for the people on the cab. You're wearing one hat. You're going to be the voice for the religious establishment. You're going to be the voice for the clinic. But that's it. Right? Don't become, or don't give me a perspective of I am the person who knows this and that and this and that and this and that. And you yourself are going to go, I'm here as the researcher. I'm telling you as from a research perspective. It might be right religiously. It might be right for the community, but it won't work. And I'm just telling you, that's my voice. So avoid dual roles, one person, one perspective. Because what happens then is if you don't do that, then the first point comes about. Then it's like, oh, this guy has a foot in every corner of the masjid. He knows everything. So he's the leader. I'm just stepping out. And this is particularly problematic for me at times, because I go in as, yes, I'm the researcher. Yes, I am the person who knows Islamic bioethics. Yes, I am the clinician. I know the clinical realm. And so now all of a sudden, like, yeah, some total knowledge, Asim, whatever you say will do. And then it all fails half the time. So that's my problem. That's Fatima knows as well. So just avoid that syndrome. And diversity. So I'm saying don't marginalize the marginalized. So we know within the masjid community, right, the mosque community at large, there are people who are not privileged in leadership positions or in titles or even in the work. So I think that we should be cognizant of that, because oftentimes we're trying to serve the underserved, then therefore it means don't marginalize the marginalized, right? Bring them into your locus of decision making. Lastly, bring people up to speed. What I mean by that is that you need to bring people up to speed in terms of what project you want to do, what thing you want to attack, whatever else it might be, what we want to tackle, what we want to accomplish, and you do that in a collaborative way. But not everybody has the same background you do. Right? So one of my teachers said this very poignantly. It was very interesting for me. He sort of said that you learned to, not in this context, you learned to read the Quran, right? I don't know how long it took you, but say, for example, Asim, it took you, 2 years to read Quran, Tajweed, whatever else it is. You're not going to expect your child to pick that up in 2 days, right? So for you, you might know everything in terms of the healthcare sector and how it's administered and everything else, but don't expect that the person in front of you will get that in a 2-hour meeting. So you might have to keep things, okay, here, I will now spend extra time explaining to you how this system works, because I got a sense in that meeting you didn't quite understand. And I'm not going to call you out in that meeting, right? Again, these are idealized ways of what we should do. They're aspirational in a certain sense, but I'm giving you these pointers from my own failures. Yeah, and this is sort of we talked about the caps, bring two people together from across the community, right? So make sure that you have, in the mosque community, you have all these different sectors of the mosque community together. All right. And lastly, incentivize. So this is going to be part of PCOR's real core mission, is to make sure you recognize that you have to incentivize everybody to do anything. There are costs that people are paying. I am cognizant of this in the sense that people often ask me to spend time on weekends doing things for them, huh? But they don't recognize that 2 weekends of my life go into clinical service, and those 2 other weekends I am doing house errands. So that means there's no weekend activities, Fatima, for me to participate in this PCOR teaching on Saturdays. Yeah. So You can't incentivize me because either you're gonna go do the laundry, right? Do that. Just take care of the laundry and shopping, and then I'll come. But if you're not doing that, I don't need your 20 bucks, right? I'm being serious. So, and I'm just picking on Fatima because I know she'll understand where this is coming from. But you have to think about that too. You might want to have meetings and say, I'm going to give someone $25, it's fine. But for them, maybe it's not the $25. It's not the coffee. It's not the donuts, whatever it is. It's the fact that operating cost for them is, I can't go do this, or I can't, right, participate that way. And so we have to recognize with the incentivization structure, and PCORI doesn't go as far as this, but I am. Sometimes it's I'm going to get you guys a meal, right? That is important to incentivize you to be here, right? So that you don't have to cook today. Think about Muslim women. Or I'm going to provide babysitting, so you can attend this meeting of women's health, so that your children are not, right, your responsibility for this time period, right? We have to incentivize appropriately for those people who can. And for everyone, it's not the same thing. All right. So I've spent too much time on these sort of preliminary slides. So let's move forward a little bit. I don't think we're going to end at 6:15. It'll take us to 6:30. So continuing engagement, you've seen this slide here, I think, this is the idea of varying levels of compensation, right? So that there are different levels that PCORI has stated as in terms of engagement with an activity or a research activity. And for me, just being an informant, being a consultant, collaborating, and then as they want, right? Stakeholder directed. In the toolkit, I've moved this into the mosque PCOR sector by thinking about what the mosque stakeholder and what the PCOR stakeholder should do together at different levels of the continuum engagement. So I'll go through this very briefly, but it's in your toolkit, right? The idea that a consultation might involve that the mosque stakeholder offers advice about how we should develop a survey, right? But to do that, the PCOR researcher to engage in consultation must then present the design, right? And coordinate and talk about how we're going to coordinate logistics. So if you want them to consult, you must give them the information and just tell them, I'm just asking for your consultation on this, right? Involvement might be, so for example, if you want to collaborate to address community concerns, you might reach out, the PCOR researcher might have to reach out to leaders to figure out their input, right? If we're going to involve them, they have to be involved at every stage of the work if we can, right? So study design, outcomes, metrics, dissemination, all of it. And that means that the stakeholder will then collaborate, right? Not just consulting, I just want to give you a check mark that it's okay. I want to collaborate in designing all of this, so I have investment in what the outcomes would be of this project. That's still a great deal of partnership. And partnership is that you're going to use all these engagement techniques throughout the entire project, right? And you're actually partnering, and the way you're partnering that's what you're doing. You're opening up the box, tell me where you want to be, what you want to do, but really the mosque stakeholder will then say, well, here are what the outcomes are important to us, and PCOR is about what's important to them, right? So that's what they're advising. They're actually partnering with you to develop a project that is of meaningfulness, or that is meaningful to them. And then that becomes smooth, strong, and Fatima will tell you this later, how to move from a project to a program that's sustainable, right? In the much of thereafter, because it's meaningful to them. It's not going to end when the project ends or the funding source ends. All right, so we talked about the continuing engagement. Now we're going to move a little bit to defining and selecting a project. So you've heard from others doing a community health assessment. I said informally, they can also do formally, and doing a SWOT analysis and identifying a topic. So let me kind of share with you what's also in your toolkit. The idea that we did the eMarch project, which predated this one, had stakeholders think about what were the most important health concerns for Muslim Americans. These are what they came up with. Okay, now this is pre-COVID, so things have changed. But they talked about these issues. Mental health came up on top. Lack of appropriate, culturally sensitive or religiously appropriate care, underutilization of preventive health care, right? It's the top three, and then reproductive and sexual health. Now, you might say, oh, these sorts of things are not what occurs in masjids topically right now, and you'd be right. But I just want to tell you that there was this notion, this idea that the masjid space, the mosque community space, should be utilized around these things very important to our community. So it wasn't tobacco smoking necessarily, or other things that other communities might have. This is what these people felt are important to tackle in our context. The task is how would you do that in the mosque community setting, and what I call what is the Muslim dimension of this work. So to go there, I'm going to have to kind of do some pre-work. So I said to you last time that our interest and the reason that we've gone to the mosque community is because we believe you can aggregate the identity of Muslims there. You can research Muslims, right? You can find Muslims there. You can do work across race and ethnicity to figure out the Muslim dimension of health. But still, there's a problem of what does the term Muslim mean, right? And so in the sense of you have to specify not just what the group is, but what the Muslim dimension of the health project or product is. So we can say that a Muslim is, a group of people with some shared characteristics, in this case, the religious identity. But that means various things in terms of Muslimness. You can have a shared identity. I call myself Muslim. We shared commitments. Well, I'm committed to follow the Quran and Sunnah. We shared experiences. Well, I am a marginalized identity within the context of Islamophobia. It could be values. I value, I don't know, gender concordant care. It could be a shared history. We are, Muslims who are living in a diaspora, who are emigrated from places where we potentially couldn't practice our faith. It could be beliefs, right? I believe in the afterlife. So there's many different things that come into this notion of being Muslim. And we're going to do a research project around in the masjid community. And my advice is we're doing that because you want to get at the Muslimness of a problem, leverage that Muslim identity. You need to be upfront about what level of this Muslimness we're talking about, right? So to do that, let me kind of move and talk a little bit for a second about the problems with this. So the problems of this notion of religion, right? Traditionally, and I'm going to skip through these slides. You'll have them obviously on the website. But traditionally, religion, the conceptualization of religion, has been one that's been a bit problematic from a researcher perspective, right? Things that focus on generalized religiosity, right? So the idea that I report I'm a religious person on a grade scale 1 to 10, and if people who have rate themselves 9 and 10 have lower blood pressure because they just say they're more religious. This notion of generalized religiosity. Right? But that hasn't worked in terms of measurement science very well. I mean, what are you going to do with that data point? So I'm going to move us forward, and so we need to think about more focused religiosity in certain ways. But before we get there, I want to deconstruct for you what I said at the beginning of the talk. Like, I want to deconstruct healthcare for a second. And these questions you don't have to answer, so don't worry about them. But the model that I use to think about healthcare is Kleinman's model, Arthur Kleinman from Harvard, and it's cultural construction of clinical reality. So he says basically that, and I think this is a very good and applicable definition, that healthcare involves the process of moving from notions, as I said, notions of illness to wellness, right? Not from being sick to healthy. Notions, being the people, of illness to notions of wellness for individuals. And this process occurs through 3 domains in society. The most common, or the one that people think most about, right, immediately comes to mind is the allopathic healthcare system in the United States. Hospitals like the one I'm sitting at, healthcare clinics, that's what we produce, right? So the allopathic system. What he calls and I'm using the term allopathic because that's what the dominant, there are obviously osteopathic and other notions here as well, but that's what he calls the professional domain, right? So in the professional domain, now this is my addition, you can think about religiosity affecting health behaviors. So how do religious people interact with the healthcare system, right, with this health behavior? And I'll give you some measurement tools there. The second domain is of moving from notions of illness to wellness is through family, social networks, and community. And that's the popular domain. What do you mean? So that's the people, that's right, the non-prescription related domain. Someone told me to take zinc for a cold. I want to take zinc for a cold. I want to go to the pharmacy, buy that zinc. I want to take it for my cold. Or vitamin C. Or my mother said, drink chicken soup. This is the popular domain that is utilized by individuals, actually more than the professional domain, for moving from illness to wellness. Okay? And here, if you think about religion, it could be how does these religious networks impact healthcare decision making, right? So is it that I'm going to try my, black seed oil first and then go to the doctor? That's where religious notions would come into play. The last domain is sort of non-professional and alternate treatments. Now, this, in the context of Muslims, might be religious-based treatments, right? And I'll talk about that, but he calls it folk domain. I don't like that term so much, but the folk domain meaning things that are not in the popular secular space, but which are brought through sort of alternate systems that have their own notions of what wellness and illness are. So in Pakistan, this might be the Hakims, right? Or in China, it might be the Chinese healthcare system, right? The sort of the traditional Chinese medicine. All right. So these all are active within our own masjid community. They're all present there. And when you're going to go and thinking about religion and religion impacting or Islam impacting health behaviors, you must cognate in your mind that these are all embedded in the masjid community. You must tease them out. Now, I'm doing research speak here, but I wanted you to at least get this idea. I'm going to skip over some of these things, these other slides, because they're, as long as you get the idea, then you can move forward. So, so I'm going to give you some practical advice. So when you embark on a project, in a PCOR project in the masjid community with a community advisory board, I think you have to think about these three domains, these climate three domains, to listen narratives of how people move from illness to health in your research area, right? What I mean for that is, say, and we're going to talk about topic selection in a second, but say your community advisory board says we want to look at Muslim youth and alcoholism, right? So you're going to say, okay, well, I need to figure out, deal with the issue of alcoholism, how all these two domains, how the professional domain of physicians, allopathic, are involved, how the community deals with people who say, or the family networks deal with people who have alcoholism, and then how, does it the imam or someone else who says, okay, well, someone comes to the imam and says, I'm dealing with alcoholism, and he says, okay, well, I want you to do this, here's the counseling, or here's the ruqya, or whatever else it is. All three are going to, at least you have to think about all three involved. Otherwise, you're going to get a partial answer. And in terms of measurement, we're going to get to this next time. Then you have to develop measurement tools for each of these domains. And this is the burden of ours who work in the Muslim community health disparity domain. That these measurement tools do not exist. You have to develop them. They're particular. I think this is a PCOR project by itself. So, being cognizant of time, I want to, so like, for example, I have in the slides that you'll see their methods, okay? I want to skip over some of these things. The popular domain, and yeah, so this is what I want to share with you, this notion, because a lot of people at this time are thinking about discrimination and Islamophobia. So this model is a model that I published about how the Islamic tradition relates to healthcare inequities. This is a conceptual model, and I want to walk through it for a second to give you a rough sense of how I envision things happen that are how things happen in the Muslim community to produce health inequities. So on the left side of the figure, we talk about health, and this model is talking about health practices within the tradition. Right? So you're starting off with, okay, I'm going to take black seed for every malady, because there's a hadith that says that is the cure for things. Or I'm going to take honey, because that's what the Quran says, fi shifa'u lin-nas, right? There's shifa in it. في بطونها شراب مختلف ألوانه وفي شفاء, right? So that in the bellies of bees there is sharab, a drink, that within it is shifa, and there's shifa, there's healing. So I want to take that and I want to run with it, right? And I want to take honey with every time I'm sick. So that health practice then can present the next era as an ethical or cultural challenge in the clinical area. Meaning, say you're diabetic and you're taking honey for diabetes. I mean, this could be a problem, right? For those who know that diabetes has to do with sugar control, right? Or that you're going to take black seed oil for your cancer treatment. So it could produce an ethical challenge when the doctor sort of says, well, I don't know if you should take honey. This is messing up your A1C. Or I don't think black seed is going to solve your your cancer issue. Or a cultural challenge, so this is a different practice. Health practices that we only are seeing in same-sex relationships, meaning physicians and providers and patients. That could lead to a cultural challenge. Well, we don't have anybody on staff who's of that background. So whether or not that cultural or ethical challenges is successfully negotiated leads to perceived discrimination, right? So I'm telling you I want a male provider because I'm a male and you don't have one, then I don't want to, right? That I could feel discriminated against, right? Or the lack of accommodation of my religious value. I want to pray during my hospitalization could lead to a pattern of healthcare seeking that's negative, right? So that's the other column. So the idea that either if you negotiate successfully, you might say, oh, yeah, I want to go to that clinic and that hospital. If you don't negotiate successfully, I don't want to go. And then that can lead to healthcare inequities. So that's the first sort of top slide. The bottom aspect, interpretation of health or lack of health based on Islamic theology, the notion here that I don't see or it could be that a patient says, you know what, mental illness is not a problem. Islam doesn't recognize it. I'm not saying that's right or wrong. I'm just saying maybe they say that, okay, well, this is something else. That interpretation of what health means or lack of health means could then inform a pattern of healthcare seeking. Well, I don't need to go see a psychiatrist or take antidepressants. And that could boost health inequities. The Muslim population at large has a different metric or measured outcome than other populations. The last bit there is adverse health exposures due to being having Muslim identity. This is where Islamophobia comes in, right? And what I mean by that is everybody wants to talk about Islamophobia, but really in my work, and I think we have to think about religious discrimination. And we know from a huge body of work in this country with minorities and particularly African Americans that discrimination leads to maladaptive behaviors, stress-related illnesses, poor mental health, and delayed healthcare seeking. So there's a whole history of that. And if we were to just change Islamophobia to religion-based discrimination against Muslims, you would have a wide body of work that you could draw upon. The fourth domain I mentioned to you, this notion of etiology of disease and ontology of cure. And these are two sort of programmatic flyers, right, that suggest that Muslim communities have different notions of etiology of disease. So we all want to do Muslim mental health work, and that suggests that there's something distinctive about Muslim mental health. Either the problem is distinctive, right? I mean, mental health means something else to Muslims, or the solution is something distinctive, right? So your assumption is that's the case. That's why we want to do Muslim mental health, not mental health workshop for Muslims in a masjid. So make your assumptions explicit. And then you have this other notion of healing through the Quran and Sunnah, right? So you have individuals who provide and purveyors of these treatments, right? Physical and spiritual ailments such as evil eye, jinn, black magic, and more. We'll give you some du'as for that. This is validated within our tradition. I'm just sort of saying that that's also distinctive, that other researchers won't really look at or know how to think about. And that's the Muslim dimension of health. Okay, we want to move forward talking about research and different types of research. And Fatima, when we talk about different types of research, here's my one slide. Well, I spend my life talking about that. You get one slide, right? Where I'm going to kind of impute upon you all you need to know at this point about research project types, okay, or designs. So she wanted me to talk about perspective versus implementation versus dissemination research versus predator effectiveness research. This is all part and parcel of the PCORI's sort of methodologies. And the simple way to get at this is these 4 questions. So I did a project I shared with you last time. We did a project in partnership with the various communities. Fatima was a part of this as well on Muslim cancer screening rates, particularly mammography screening rates amongst Muslim women in Chicagoland. So a perspective research would be, do Muslims have lower cancer screening rates? Like, that's it, right? It's perspective. I am collecting data on this question. And this question is, do we actually have lower cancer screening rates? We did surveys at masjids, 13, I think, masjids and community centers to figure out whether Muslim women had lower mammography screening rates than others. That's perspective data collection, right? Implementation research would be, right? The question would be, how do we, there's a cancer screening guideline. Women over the age of 45 should get a mammogram every 1 to 2 years, right? So the implementation of that guideline from external to the community, from outside the community, how well is that implemented in the Muslim community? So do Muslims follow cancer screening guidelines? Or how well do Muslim women follow cancer screening guidelines that are given to them by their doctors or healthcare clinics? So you're implementing a guideline or a advisory body's regulation. How well is that implemented is one notion. The second notion would be, how can we implement it, right? So the implementation of this guideline in the community, how we would do that. So there's two dimensions there. The dissemination would be, right? Dissemination research in this case would be, would this cancer screening program, so you have a program, a cancer screening program that works in the African American community in Mali. Can that program work for the African American Muslim community in Chicago? Right? So the notion here is that I'm implementing that work, but that's also dissemination research, right? They have disseminated a product there. How well is that dissemination product taken up here? So there's a little bit of overlapping between D&I, dissemination implementation research. Lastly, colonoscopy or fecal occult testing more effective in Muslims. So comparative effectiveness, two different modalities between cancer screening. Colonoscopy every 5 or 10 years. Fecal occult blood testing every year, 3 times at your doctor. Which one's more effective for Muslims? Do Muslims have different valence towards each of these guidelines, and which works better for Muslim populations? Again, it's all broken down to one slide. There's nuances there, but I want you to get a sense of these different types of research. Now we're getting closer to the end. Alhamdulillah, I caught up a little bit. And the last bit here is what Sister Fatima I talked to you about, was this model of tailored messaging, right? So I want to share with you this 3R model. Again, there's a citation there. And in our view, this could be a communication tool that you all could use with mosques, stakeholders, and CAB members, but it's grew out of an intervention. So the idea here was, well, I want to create a health message that is religiously tailored for the Muslim community to get them towards moving towards a healthy behavior. Again, this is from our breast cancer work. So we wanted to elicit barrier beliefs, meaning things that problematize getting this health behavior done or accomplished, right? So in our context, what were the barrier beliefs Muslim women had that prevented them from getting a mammogram? Once you understand and solicit what those barrier beliefs are, meaning I believe, so this is not the case in our work, but I believe that getting a mammogram actually gives you cancer, right? You would need to solicit one of those barrier beliefs. What do people think in their mind about that modality? And then you have to think, okay, well, is that barrier belief aligning with when you want to religiously tailor it, right? Is it aligned with religious theology, or is it not? That's the first step, right? Because whatever message we give to combat that belief, we want to make sure that we first want to recognize whether that belief is religiously rooted or not, right? So if it is religiously rooted, that's the bottom part, right? So say, for example, if the belief does not, it's not consistent with the religious theology. Say, for example, the idea that in our case, I'll give you some examples later on, that God decrees what happens to me at all times, therefore I should do nothing else. Right? Oh no, sorry, let me take a different example. Let me take the example that Islamic law says you can only see a Muslim female can only see a Muslim female doctor, right? Like if that's your belief, but we know that there's a problem to that notion, that's not exactly the verdict, then you can reform that belief. No, actually that is true, but in exceptional circumstances, that is not true, right? So you deliver a message that reforms that barrier belief, so it aligns fully with religious theology or doctrines. If the belief aligns with religious theology, then meaning that, no, that's true, say that's the notion that, then you cannot reform that belief, right? You can't, because you would negate the religious belief, and that would be wrong, because actually that's what religion says. So then you have to use 2 different techniques, reframing and reprioritizing. So reframing means that you then try to think of a message that reframes that health behavior in terms of something that's religiously consonant. I'll be clear in a second. Reprioritizing this, or the belief would mean that you reprioritize, you give them a different belief to hold on to, and hope and keep on hitting on that belief so that it becomes more important to them to hold to that religious belief than the other one. So here are now some concrete examples. I've highlighted 2 of them. So the idea is that, say, this is from our own research in Chicagoland, that there's a belief that mammography is painful, stop women from getting a mammogram. So to reframe that, well, first question, is it religiously, consonant, this notion? Well, the answer is this belief has nothing to do with religion, right? So therefore, we don't have to reform it, and we don't have to reform our religious belief because there's no religious belief to reform. Secondarily, we can't reform it medically because actually they are painful. So to tailor a message, we had 2 options: reframing or reprioritizing. So reframing was make that health behavior, getting a mammogram, framed in a way that's consistent with a religious notion. So here's the reframe: the payment incurred on the path to a good deed, right, is rewarded by God. That's true religiously. So now you have not done anything to bury your belief. That's true. Mammograms are painful, but I've reframed that pain in a way that it's religiously consonant and beneficial towards getting a mammogram. Or you reprioritize that I hit on a belief that's religiously consonant, that's theologically sound, has nothing to do with that bury belief, and I keep on hitting on it so that they believe this is more important, right? So you have a surely responsibility to care for your body that God has given you, and cancer screening coheres with that duty. You keep on hitting on that message so that in the end, okay, yeah, mammograms are paying for it, but look, I have a responsibility to my body, and that comes first. The bottom thing I highlighted was a different now. It is Allah's will that I am sick or cured, and Assalamu alaikum, can you hear me again? I don't know what happened. Yeah? Yeah? Okay. So let me just, I think when Maghrib comes in, my computer shuts off. It's like a Muslim computer. Anyway, so the second line here, it is by Allah's will that I'm sick or cured and I can do nothing to change my fate. So is that religiously consonant, right? So the notion is, well, that's religiously related, but it's not actually true religiously, right? We can reform that. So I'm going to the last column here. Actually, human actions can have effect, right? We make dua for that purpose, to change our decree from our vantage point. Therefore, you reform the belief by giving them a more constant religious idea. As far as the other 2 options, reframing and reprioritizing, you can certainly employ them. In this case, you can't do reframing because mammography screening has nothing to do with God's control over disease and cure, right? That's the belief. God's will judges being sick or cured. Getting cancer screening has nothing to do with this notion of God's control over sickness and healing. You get it? There's nothing, you're just getting cancer screening test. If you have cancer, God will decide. If you don't have cancer, God will decide. If you get cured, you'll decide, right? The screening test has no implication upon whether or not you're going to be healed or cured or have the disease. So you can use that reframe here. Reprioritizing, again, is the same idea. You have a duty to care for your body. So my point only here is that you have to first recognize what the beliefs, problematic barrier beliefs are, and then use this sort of tailoring to get around those. Now, I can spend all day on this. I spend usually more time than this on this notion. So the next, but I want to give you a infographic. I don't know, my screen's not moving. Hold on one second. Do you see the next slide? No? Yeah. So here's a schematic before we end quickly. The way to think about the 3R model and a sort of different analogy. So reframing means switching train tracks, meaning that you want them to get to, you think about it this way. The train carriage is the belief. The destination is the destination you want to get to, right? The city you want the train to end to. So reframing is switching the train tracks, flipping the switch on the train track so that people take that belief, right, and they go to the other destination. You reframed it such that that belief now is actually going. You flip the train tracks, so it's actually going where you want to go. So people want to go from New York to Philadelphia. People want to go to Philadelphia. You wanted to go to New York. You flip the track right in Pennsylvania. I'm sorry, in New Jersey. So they go to Pennsylvania and not whatever, New York. You understand what I'm saying? The second notion is reprioritize, right? So now you say, okay, there are all these people on this train carriage, this belief. But what I'm going to do is I'm going to show them a higher class, first class sleeper car train. I'm going to say, get on this train, not that train. So they, right, you give them another notion. Like in our case was stewardship responsibility to your body, telling them how great that belief is. So they say, yeah, I don't care about my train. I don't care about the destination I was going to go to, right? Whether it was Philadelphia, I actually want to go to New York, and I'm going to get this nice bullet train to get me there. Then the other day, as you're forming here, is right. So you say, okay, no, this is a wrong belief. Then you sit there and spend the time to actually blow up that belief, right? And therefore, when that belief is blown up, they can't get on that train. They can't go anywhere. Anyway, another way to think about that. So now before we really end, inshallah, so you can have some time with me before we end for Maghrib. Next, we're going to go is the P-Core life cycle, right? We talked about planning a bit. We're going to talk next about conducting. So planning was this notion of setting up a cab, identifying a research topic, sort of the engagement principles. Next time, we're going to take a deep dive into sort of conducting the project itself, and liaising between the mosque community stakeholders and the P-Core team. So this slide set, Dr. Fatima wants me to show you all the time that these are the masjids you guys are going to be assigned to or have been assigned to. So remember, those are your virtual social networks. Okay, khair. Ending there, but I'll take some questions, inshallah, for the next 5-10 minutes, inshallah. Jazakallah khair.
Assalamu alaikum, Dr. Padilla. I have a question with regards to when you said don't wear more than one hat and to just focus on one thing that really good and talk about it. But what if you see something that's wrong, or there's a topic that you're really knowledgeable about and no one's bringing it up, or it's being addressed in a wrong way? How do you tackle that with keeping that one hat on?
I was saying in the context of your being on as part of the community advisory board and being the facilitator of that board, that you should come in saying, I'm wearing this one hat. I'm speaking for the benefit of the research project, right? And others say, well, I'm presenting the view of a religious leader. Because if you say, no, I know 5 different domains and you don't, it sets up a non-equitable voice structure. So I'm not saying, so your thing was if something's done wrong, yeah, okay, I'm telling you as a, I don't know, expert in this domain, this is not the right way to do it. Fine. But you can't say, oh, so I agree with this notion. If something's done incorrectly, then you say this is not the way to do it. But you're saying I'm lending my expertise, right? In the context of this project and this community advisory board, that's what I'm speaking to. And there is another expert who's the expert in the religious domain or in the implementation domain or in what happens in the masjid domain. Because you want them to participate as experts, right? They have insider knowledge that you might not. That's what I'm saying. If you go in with this notion that you have all the knowledge in hand, you will inhibit their participation, ultimately shoot yourself in the foot when you need their help. So that's as this aspirational notion you must go in with, to recognize the cost of your saying, I know all these domains. I am the religious expert. I am the researcher expert. I am the blah, blah, blah expert. Well, then say, okay, then you know everything. You don't need us. I hope that's clear.
Okay, so just to clarify it more, so like in a situation like that, if you would want to highlight that problem or that like belief, and then like refer it to the expert for that person to like chime in with their perspective.
Correct, right? So I could say, so let's take this belief of like if the belief here was God controls disease and cure, you can say, well, my reading of the literature is that that's true, right? How he says that. And when so and so doesn't God change our faith, how should we deal with this? Right. So I'm sort of saying that you want to bring people in on board to whatever you're doing. It could be I can answer that question, but if you do that too much, then I'm going to answer all these questions from all these domains. Then your cap's going to say that's going to happen. You're going to inhibit equity of voice. That's the cost. So I'm telling you the cost of doing that, even though you might have multiple domains of expertise. And in your initial meet and greet and all these initial phases, when people don't know you, you need to really listen and not be the expert in everything.
Jazakallah khairan.
Okay.
So like to work on that example, like God controls like if you have disease or not. Like what if you address something like that and then you like tell them your perspective or try to change their mind and they get offended by that. Like there's there may be like some people who just get offended by you trying to change their perspective on a certain topic. So what would you do?
But I'm not fully understanding what you're sort of saying, but you in the role of this context of this project are not working to change anybody's beliefs about anything, right? And you're not the interventionalist in that sense, right? So I think people get offended when they when you're trying, right? I think people get offended, generally speaking, when you are trying to tell them you know something and that they don't know something, generally speaking. Now, right, because they feel, what's the word? They feel lack of validation about their own knowledge, particularly around whatever the issue is. Insecure is the term. Now, in the context of this project, you're not shaping anybody, you're not going to be reforming anybody's beliefs about anything. That's not your role as a community health worker. I think it's going to be problematic if you try to do that. You are the liaison between health experts and religious experts in the context of this project. So let me give you a more concrete example. So say you said, in COVID-19, I know that all what this will mean for us in our masjid, and therefore we should keep the masjid closed. Well, you're not Dr. Fauci, you're not the CDC. And a better tactic would be, well, this is what health experts are saying. Here's the data. What do you, mosque leaders who know the masjid, think about that? So I think that you need to recognize your role in this context, this project, and the professionalization of the community health worker for mosque, or that you are always a liaison between different knowledge communities, not the knowledge giver. Otherwise, you are the interventionalist, and then you should have someone else be the community health worker. Your role is intersectional. Maybe Fatima can chime in here.
Yeah. But I think I understand Abdurrahman's question perhaps in a different way. And what he's trying to say, as soon as you start a conversation about something, the person may get offended, and that has happened, or it happens to us occasionally, because we may come out in a different way. So it's basically choosing the words carefully, or the way we are presenting something, or avoiding a misconception. I think, is that what you were asking, Abdurrahman?
Yeah, like I don't know, for example, like maybe elderly Desi people maybe may get offended by you introducing some kind of idea to them because they're used to thinking of it in a certain way. Kind
Yeah.
of thing.
So basically what Dr. Bjela is saying, and actually what I have understood or I have picked up from Picori and our previous sessions in the eMart is that we don't want to present something. We want to hear from them. We want to know what helps them, what matters to them. Just simply listening and trying to understand them more. That's the known and known unknowns kind of that's the realm. So we are primarily exploring. We're basically community health workers, and we are simply exploring. That's all we are doing. That's what at least my intention is with this aspect as well.
Right, and then when we intervene, it's intervening on the back of authorities of others outside of us. Right. So the religious scholar, the imam, this is what the religious verdicts on this, or the health authorities. This is what the CDC recommends, right? And American Cancer Society recommends. So we're not putting the onus of I am the expert, rather I am the conduit for this expertise. I'm delivering it to you. You can do with it what you like, right? But my role is to facilitate bringing these knowledge communities to you, and maybe I'll shape that communique in a certain way based on the community advisory board's input about what needs to be, how it needs to be displayed or communicated. And I'll use a 3R model to, right, potentially reform these sorts of beliefs in certain ways. I mean, reprioritize, reframe these beliefs in certain ways. But I'm doing that in the context on the context of having people who are authorities, be they medical authorities, religious authorities, or cultural authorities, inform that intervention. So you are then you are not the interventionist. I am not the intervention. My words are the intervention. Rather, I am the conveyor of information from others who've given me that knowledge. If you are, that's why, and I'm saying that because then you set up a problematic where it becomes about you, and you're leveraging yourself, and you're in a very vulnerable position then, because you're new to this community, and you have a power differential and a knowledge differential, and they might not see you as a person. Like obviously, they're not. I mean, there are other people who have that authority, so to speak, or that expertise that they might trust more. That's a good question, nonetheless. I think your role in the context is probably will not be at that level, as Fatima said. It's much more of a listening. So I'm calling on time's up. You're welcome. Oh, yeah. I think time's up, but if there's one more pressing question, I could stay, but then I think we should go here.
Dr. Padela, there is a question on the chat.
Okay. That's correct. So bias in the cabinet, this is why I'm saying equity of voice, right? So you come in with presence, and you listen with presence, and you say, well, we want to hear these multiple perspectives. Each one holds some lens that can help us get a better sense of what is going on in the community, because you're assessing, you're doing using assessments, right? And that notion is important to the intervention that we need to do at the end. If we knew what to do, then it would already occur, and the mosques would be hotbeds of health, but they're not. That's it, and that's how you do it, right? So in general, it's not bias; it's the fact you have to learn techniques by which you can facilitate equity of voice and group facilitation around a CAB. And the generational divide is real. Most people are you tell me what to do, I'll think about it, and maybe I'll do it, as opposed to let's together get on the board of trying to do something. It's harder, and the cost is yours. So I was trying to get you a sense that being a community health worker in the context of masjid is going to be try your patience. So our next dua maybe should be about sabr. Or safe. Yeah. So, well, inshallah, you'll have me next week as well again. So,
inshallah, Mother, we will have an open session on Saturday, and our doors will be open at the Glendale Heights office. So so when the invite goes out, it would actually be for the hybrid. You will have an option to be on the screen as well, or attend virtually, as well as you can walk into our office and attend it from there as well.
Right. Okay, everybody. I'll see you soon. May Allah bless you all. Keep safe. All right. Assalamu alaikum.
Walaikum assalam. Jazakumullah khairan, Dr. Patel.
Welcome.
Sister Rose, you can stop the recording.